And I was told to wait about 30 seconds for you all to file in. So please give us just a moment and I will start momentarily. We have such a great panel and such a treat in the investigators here. All right. Well, I think I've waited my obligatory 30 to 45 seconds, and my heart is excited to introduce this fantastic panel. Welcome, everyone, to the Digital Health Intervention panel discussion. My name is Dr. Marquita Lewis Thames. I am your moderator today. I have an amazing opportunity to introduce our panelists today, you all. I just want to kind of get out. What is our goal today? What are we trying to do on this Zoom that we have such a hard time trying to draw connections to? Well, one, we want to draw connections, and we want to draw connections really focusing on two main things here, this idea of health literacy and digital interventions. Let that sink in. Health literacy crossed with digital tool interventions. And so our goal is to really present different perspectives on developing digital interventions, including the methods and the types of tools that are involved. And our second goal is to address how we demonstrate that there are different types of literacy and how that literacy transcends multiple populations and how we can actually bring the marriage of understanding those digital tool developments and improving health literacy. Today's panelists include Dr. Andrea Graham, Dr. Andrew Berry, as well as Mr. William Liam. And they will be talking about three different types of populations in which we will address health literacy and digital tool development. I also would like to say that I am a researcher focused on digital tool development in rural health populations and would be happy to also and happy to talk about later on with the panelists how we're addressing health equity and how we're looking at those digital tool interventions and health literacy with marginalized populations. With that being said, I'm going to introduce our first panelist. That will be Mr. William Liam. Would you like to go ahead and start sharing your presentation? And I'll give you a quick intro. I also like to say, just kind of logistically, you all please feel free if you have any questions to put your questions in the Q&A. I will be monitoring those. We are going to save questions to the end of the presentation, but please, we're hungry for those questions. We're hungry for that engagement. Now, Mr. William Liam is a PhD student at Northwestern University, and he's specializing in human-centered AI and LGBTQ plus health. His research focuses on co-creating responsible AI technologies that promote the well-being of sexual and gender minorities. Mr. Liam has an extensive experience bridging industry and academia through research design and system science, consulting for tech companies like Google and Meta. I'm kind of scared of you now, Mr. Liam, with expertise in algorithm fairness and participatory AI. Let's give up some moments, our time for Mr. Liam as he discussed co-designing on equitable AI sexual health education tool with queer teens.
Right. Thank you so much for the very warm welcome, Marquita. Hello, everyone. My name is Will, and thank you for giving the opportunity to present today. For today, I'll be talking more about the motivation behind my dissertation project and also connect the relevance between AI literacy and health literacy. But first, let's do some context setting. So in the US, LGBTQ plus teens represent a rapidly growing community of the US population, with approximately 1 in 5 Gen Z identifying as LGBTQ plus. And this number is projected to grow over the years as the social cultural climate behind queer acceptance is becoming more inclusive across the US, despite the rise of anti-LGBTQ policies across certain states. And as we look at the current state of sexual health education across the country, we see that 72% of sex ed programs completely omit LGBTQ plus topics. This means that the majority of queer youth are navigating sexual and gender identity without formal guidance or resources that reflect their full experience. Furthermore, essential topics like sexual and emotional abuse within queer relationships are also absent from most curricula, leaving a lot of queer teens to learn about healthy relationships through trial and error, personal experiences, or online sources. And these omissions aren't just gaps in education. They're actually part of a broader structural issue that prevent a lot of queer youth from accessing the knowledge they need to understand and articulate their identities and experiences. And so this structural issue is known as hermeneutic injustice, where it's a situation where a marginalized group is prevented from making sense of their own experiences due to a gap in the collective understanding or language in the society. The structural exclusion of queer censored sexual health education is a form of hermeneutic injustice because it prevents queer youth from accessing the knowledge and conceptual tools they need to understand and articulate their own experiences. This epistemic gap creates significant barriers to their health, well-being, and sense of self. And so to further cement this idea, I'd like to introduce us to a metaphor. So imagine trying to understand yourself without ever having access to a mirror. A mirror allows us to reflect on who we are. It helps us see ourselves clearly, identify our features, and make sense of what we see. But for a lot of queer adolescents, the lack of inclusive sexual health education is like being denied a mirror. They're left without the tools to reflect on their own experiences, relationships, and identities, and without the language to do so either. Without this mirror, they struggle to understand themselves in the context of their sexuality and gender identity, and forced to make sense of their health and relationship through fragments of information, which can be often unreliable or inaccurate. And this confusion can lead to harm, especially in recognizing things like healthy versus abusive dynamics in relationships. And this is what I mean by hermeneutic injustice. Society, by excluding queer specific education, denies these young people the conceptual resources to see themselves clearly. Just like trying to understand your reflection without a mirror, they're left searching for understanding without the necessary tools, which prevents them from fully articulating or grasping their experiences. And so, as a result of a lot of these structural barriers, queer teens are often left seeking sexual health information online. As you can see in this graph on the left here, a lot of queer youth are much more likely to seek information about sexuality, general health, or medical information online more than their heterosexual peers. However, this also tasks them with the burden to sift through a lot of different types of reliable content online. And especially in this era where we're privy to a lot of misinformation, disinformation, this is a very complicated task that a lot of queer teens have to sift through and navigate on their own. And so tying this back to AI, which is where my project sits, we're seeing an uptick in personalized AI for healthcare among Gen Z, where 1 in 5 teens actively use generative AI tools, and almost 1 in 3 among young adults aged 18 to 24. Furthermore, nearly 1 in 3 people under the age of 24 are turning to large language models like ChatGPT for personalized health information, both for physical and mental health needs. Given the structural barriers that a lot of queer youth face in accessing inclusive health education, it's likely that many of these users are queer individuals who, in the absence of reliable formal education, are forced to seek health information through online platforms. This really underscores the importance of ensuring that AI tools are designed with inclusivity in mind, as these technologies are becoming key sources of information for marginalized communities. However, it's a very well-known fact that AI models are biased based on the training data that it's built on. AI models are often trained on cisnormative and heteronormative data sets, which can cause models to pose potential harms such as misgendering, which is particularly concerning for trans and non-binary people who might be struggling to understand and articulate their gender identity. Further, I want to highlight this quote by mathematician Kathy O'Neill, where she beautifully describes algorithms are opinions embedded in code. And this just really highlights that a lot of these powerful tools are not necessarily designed with the end users in mind. And so I asked myself, how might we tailor these tools to meet the needs of queer teens? Well, all roads within the literature point to including queer people in the AI development process, which is exactly what my project aims to do. So for my project, I'm planning on engaging in a set of different human-centered design methods to develop and test a custom ChatGPT with queer teens. I'm working with a really brilliant group of 20 queer teens who we partner with to develop queer teen-friendly digital health interventions from Northwestern's Institute for Sexual Gender Minority Health and Wellbeing. This group of teens is known as the Youth Advisory Council. I also want to note that it's critical to understand that a lot of queer teens have unique experiences that shape their engagement with both health and technology. For example, a lot of these teens may have experienced bias or discrimination in traditional healthcare settings, making them less likely to trust digital health tools. And this is why it's very important to understand context-specific factors, such as important roles in both health literacy and AI literacy. So by involving these teens in a co-design process, we help them develop a deeper understanding of AI. And in return, these insights allow us to create a tool that resonates with their experiences. This reciprocal process not only makes AI more effective, but also boosts the teen confidence in using it to seek the health information they need. So at the end of this project, we're hoping to create a queer-centric custom chat GPT designed by teens for teens, a glossary of AI terms that'll help unfamiliar users get a lay of the land, interactive guides and tutorials, and some safer navigation guidelines of LLMs as we are in the beginnings of a technology revolution. And so one of the most exciting things about this project is how it fosters AI literacy among teens who participate. So Long and McGarrico define AI literacy as a set of competencies that enable individuals to critically evaluate, communicate, and collaborate with AI technologies and use AI as a tool online, at home, or in a workspace. Within the context of my project, however, AI literacy isn't just about understanding how AI works. It's about understanding how to critically engage with AI tools, question the information they provide, and use them effectively. By participating in this design process, teens are learning these skills firsthand. In our co-design workshops, for example, teens are exposed to how an AI model works, what kinds of biases it might have, and how to improve its outputs. And as they build their understanding of AI, they become better equipped to engage with it as users. This in turn improves the AI itself because the feedback they provide helps us refine the tool to meet their needs, and it's a feedback loop. Better AI literacy leads to better AI tools, and better tools lead to better health literacy. And so this leads me to a key argument where I believe that within this context, AI literacy is directly tied to health literacy. And it does so in the following ways. When queer teens understand how AI tools work, they're able to engage more critically with the health information they receive. This means that they can assess the relevance and accuracy of the content provided by AI instead of just passively accepting it and accepting it for what it is. AI literacy empowers teens to become active participants in their healthcare decisions, where instead of relying solely on external guidance, they can use these tools to find tailored health information that addresses their specific needs. Furthermore, when teens are equipped to navigate AI-generated health content, they're better positioned to make informed decisions about their physical and mental health, which hopefully leads to better health outcomes. And lastly, understanding AI also helps teens recognize potential biases or inaccuracies. This skill is critical for marginalized groups like queer teens who may encounter health content that doesn't fully reflect their experiences. So, as we've discussed, the lack of inclusive sexual health education creates this some phenomenon of hermeneutic injustice, where queer teens are denied the tools to understand their own health and identity. And this gap in knowledge leaves them without the conceptual resources needed to make sense of their experiences. I argue that AI tools have the potential to bridge this health literacy gap by providing accessible, personalized sexual health information, as they offer a way to address the missing mirror, if you will, by giving queer youth the ability to better understand and engage with their health. However, for these AI tools to make a meaningful impact, they must be designed with queer teens in mind. It's not enough just to give generic resources. We need to involve teens in the design process to ensure the tools reflect their unique needs. By developing the AI tool, I'm hoping the interactive guides and tutorials will help teens become better informed, engaged users. And these resources will teach them to how to navigate AI effectively, critically engage with this information, and make empowered decisions about their health. And so in conclusion, by centering queer teens in both the design and usage of these tools, we can start dismantling this phenomenon of hermeneutic injustice that they face and also give them the resources they've been denied for so long. Thank you, and I look forward to your questions in the discussion.
Thank you so much, Will. This fantastic, fantastic. Please again, contribute your questions to the discussion later on. We will be talking after everybody has given their presentation. We'll be opening up for discussion. Now, our next presenter is Dr. Andrew Berry, and Dr. Andrew Berry is an assistant professor at Northwestern University. He is an expert in applying human-centered design methods to improve the well-being and health of individuals. He is passionate about designing health services to be responsive to the values, capacity, and needs of people seeking care. And he has declared that part of his own mission as a design researcher is to work within the medical school in order to build capacity in human-centered design methods and health services research, which includes his productivity through research, teaching, and mentoring early career researchers. I will now give the floor up to Dr. Berry.
Thank you so much, Marquita, and thank you all for joining us today. I'm really excited to be part of this panel. So today I want to talk through some different forms of literacy I've seen emerge in my work, and talk through some different phases of a human-centered design process to try to promote more values-aligned healthcare for people with multiple chronic health conditions. So these are two of the questions that sort of animate a lot of my research. How might we redesign healthcare to be more responsive to the values of people, including those with multiple chronic conditions? And how might we support patient-clinician communication about patients' values? So a little bit more background. I'm interested in supporting care for people with multiple chronic conditions because this population is large and growing. So this image is showing that for people 65 years and older, 81% of them have 2 or more chronic conditions. Living with multiple chronic conditions is challenging. So for patients that, imagine that you have diabetes and chronic pain. So if you have diabetes, your doctor is going to recommend that you exercise to manage blood sugar. But if you have chronic pain, exercising can be really painful. Throw depression into the mix, and it just gets really complicated. And it really comes down sort of to each individual's priorities for how they want to deal with those trade-offs. This is also challenging for clinicians because disease-specific guidelines for diabetes versus osteoarthritis might conflict. Furthermore, patients and clinicians often decide among these competing demands differently. So they often have discordant priorities. And conflicting priorities between patients and clinicians can lead to worse patient experiences, loss to follow-up, and less engagement in their care. My angle on this work is to focus on patients' values because their values inform their health priorities. To reach shared priorities for care between patients and clinicians, providers really need to understand patients' values. In my research, I use a human-centered design approach. If you're not familiar with human-centered design, it's an iterative process that involves centering key constituents in the design process. So people who might use the technology you develop, and also others who are affected by the use of that tool. Often it proceeds across a few phases, including understanding the context of use, specifying requirements for the thing you're developing, and then iteratively developing, prototyping, and testing out a tool until eventually it meets users' needs. So I'll talk about a few different studies I did, all of which contribute to this long arc of a human-centered design process. So in home visits and interviews with patients, so with older adults, we wanted to just understand what matters to people. What do they consider important to their well-being and health? So we gave people Polaroid cameras and asked them to photograph what mattered to them in their daily life. And then we visited them at home and talked through what they considered important. And one of the main outcomes of these home visits was a framework, a set of 6 domains that characterize the breadth of patients' values. So these domains are abilities, activities, emotions, possessions, principles, and relationships. We've translated those domains into some tools for eliciting patients' values that we used in later research. And we're always thinking through what kinds of tools we could create for actual clinical care as well. After understanding what matters to patients, we wanted to understand to what extent are patients and clinicians talking about these 6 domains of values in clinic visits. So we observed primary care clinic visits and also interviewed patients and clinicians after those visits. We found a few things that were published across a few different studies. Overall, we found a communication boundary between patients and clinicians regarding what patients consider important in their life. And this boundary is mutually reinforced. So on the patient side, patients often withhold values that they perceive as not pertinent to their healthcare. On the clinician side, many of them really are striving to understand what matters to patients. But when they develop that understanding, they often employ patients' values to serve their own priorities. So, you like to fish, right? If you don't manage your diabetes, your fingertips are going to get numb and you're not going to be able to tie the fly on the end of the fly line. And so there's this mutually reinforced communication boundary. And then in the visits where we did see communication about values, we observed a lot of work that it took for care planning to actually be responsive to those values. So it's not just a matter of saying, or not as simple as asking what's important to you and then applying that to care planning. It's sort of a process of mutually working out the pertinence of values to that patient's healthcare. So given this communication boundary, then we started doing some prototyping work. And I'm not going to show you everything we've tried, but I'll give you a few examples just to give you a sense of how we go about this prototyping process. So in one study, we did paper prototyping of interactive tools. And I'll talk through two of these prototypes, MyList and communication and conversation canvas. So in the MyList prototype, this was one proposal for an intervention to help patients think through their values, what matters to them, think through what's going on with their health, and make connections between those two things. So in MyList, the basic idea is, hey, you have a visit coming up with your primary care clinician. We want to help you prepare. So create a list of items to talk with the doctor about, and then link your personal values, your self-management, self-care duties, and health outcomes to the items on that list. So the goal was to arrive at that visit with a values-informed set of visit priorities. In testing this paper prototype with patients, we found that they really liked it because it's familiar. Lots of us already sort of have a process for preparing for a visit. They liked that it could serve as a memory aid during the visit and could help anchor the conversation with the doctor on their values. But we also found that this prototype did not overcome these well-documented communication boundaries. So specifically, when using this prototype, people were still filtering down what they shared based on what they thought their doctors wanted to hear, rather than kind of expanding the topics according to their own values. Another tool we tested out was called Conversation Canvas. So this is a collaborative conversation between a patient and a facilitator, where they both use a digital tool that serves as kind of a shared visual space. And the basic flow is the patient connects with a facilitator, maybe via Zoom. They choose a topic for the conversation. So I'm thinking through an important life decision, such as deciding to move in with my daughter across the state. And then the facilitator asks the patient to share values and self-care duties and so on that relate to that decision. And as the conversation progresses, they sort of map out visually connections between all of those different topics. So patients, we found that externalizing these ideas, this kind of complex web of values and health priorities, supported both the patient or the participant and the facilitator in sort of seeing new connections, seeing new possibilities, reaching clarity. Emotionally, it was sort of mixed. Some patients really liked talking through this in depth, and others were not as comfortable kind of navigating difficult emotions involved. But by the end, most participants were disappointed that there wasn't a clear concluding step to this prototype. They were like, oh, I just spent an hour talking through everything that matters to me and so on, but there wasn't a step to sort of communicate that to a clinician. I'm going to skip the time machine. So by testing these prototypes iteratively with patients, we were able to develop a few design guidelines for a tool that can support collaborative reflection on values and health. So it's important to first open with an exploratory, reflective conversation. Don't constrain it too early. Let the patient set the terms of the conversation. And then as the conversation unfolds, map it. Externalize ideas, visualize their connections. Then make sure you conclude with some key takeaways and align that conclusion with established practices. So for example, after a long conversation, write down a few topics for the patient to talk with their doctor about at an upcoming visit and send those in an in-basket message to the EHR. So we continued this process. We actually tested a real interactive tool. I don't have time to get into that today, but just wanted to give you a sense of how we approached this design process. And then I want to talk about a few key takeaways. So one main takeaway of this work is that through reflection with interactive systems, so digital tools and skilled facilitators, people can connect their values and their health. So we can overcome this sort of communication boundary from the patient side. And to enable effective collaborative management of multiple chronic conditions, there are at least two kinds of health literacy involved here that I think are a bit innovative and worth thinking through more. So first, it's important to support self-knowledge of values, so a kind of self-literacy. And second, it's really important to support the relational aspects of health literacy. So through a conversation with a trusted facilitator and through feeling heard, patients were able to develop a kind of self-literacy that wasn't possible otherwise. So I look forward to your questions, and thank you for listening.
Thank you, Dr. Berry. I wish you had more time to go through that prototyping process and those takeaways. So I look forward to a rich discussion after everybody has spoke. I do want to reiterate, please feel free to use your Q&A option button at the end for any questions to add to this very rich discussion. I also want to point out that the numbers of participants are steadily rising. And so this is such an exciting opportunity here to just have a rich and exciting discussion. With that being said, I'm going to introduce our final panelist, who is honestly a personal peer mentor of mine. Dr. Andrea Graham is an assistant professor at Northwestern University, and Dr. Graham's research program focuses on design, optimization, and implementation of digital development and behavioral health interventions, digital mental, and behavioral health interventions. She applies a human-centered design method to design digital tools that meet users' needs and implementation plans that support the integration of digital interventions into practice. She is a highly accomplished researcher, mentor, and just a good human. She has funding from national, foundational, and internal funders, so much so that her productivity has shown herself to be able to earn the position of Division Chief, inaugural Division Chief of Implementation Science for the Department of Medical Social Science. With that being said, I'm going to give the floor up to Dr. Graham as she will round out and finalize our panel discussion.
Thank you, Marquita. I'm embarrassed and blushing and very honored by your introduction, and appreciate this chance to get my new title was announced last week. So this is such a treat. Thank you, Andrew, and the committee and the conference, for having me for this topic. So one of the things when we were planning this, I really want to acknowledge that I am a clinical psychologist by training and an intervention and implementation scientist. And I have to admit that I am not someone who has thought a lot about health literacy until the past few years in terms of my training. And so really hope we can use our discussion time. I'm very eager to keep learning. But my goal is to share how I really sort of drinking a lot of the Kool-Aid around this human-centered design methodology, but also as an approach to really being mindful of the health literacy of the interventions I'm designing from a mental and behavioral health perspective, and some of the tools that I've done to really approach that, particularly as an early career researcher where budgets were tight. And that's going to be relevant to some of what I'm going to describe. And so the methods that Andrew was just presenting on and that Will's using in his work as well is, learning human-centered design. That is not what my training during my doctorate was about, but it's really been the pivot point of my career. And it's become completely sort of what's infused throughout all of my research now is really engaging with people to understand their needs. And really what my program of research primarily focuses on is this clinical gap, speaking of people's needs, in really helping to understand people who struggle with binge eating, so eating large amounts of food and feeling out of control, who also want to better manage their weight and lose weight. And when I was first starting in my career, and to be perfectly frank, it's still continuing, that there's this clinical gap for this population in terms of the availability of services. And so to Andrew's point about literacy, right? Like people were struggling. They had this value that they wanted to meet two different health goals, but there was not a clinical opportunity to do so. And so I really translated that into Food Steps, the intervention you see here, which was supported by generous funding from the National Institutes of Health. And it was really designed to tackle this fancy theoretical model that I put together to write the grant. And, so it's a series of boxes. And the reason I show this is not because I need you to know the model or that I need you to care about binge eating and weight management, although wonderful if you would. But what's important is that really as I describe it, the pivot point of my career is really recognizing that as a clinical psychologist, what I think that people need doesn't necessarily translate with how people use their phones, how people want to interact with an app, how people want to interact with a health app, and how they need to access these kinds of tools to help them change their behaviors, their health behaviors. And quite frankly, I then embarked on a huge amount of human-centered design work in prep for building this tool, quite frankly. And none of this, for those who are new to human-centered design, I often get a question around like, do you just build whatever patients want? And that is not correct. It's very much grounded in this theoretical model that you see on the screen in terms of what we know empirically can help people, but how we package that tool changes over time. And is really grounded in what people need. And so I show you this picture. These are a series of images from screenshots from the first iteration of my app. And if you're thinking, oh, they're kind of ugly, you are correct. And that is exactly the feedback we got from people. And one of the biggest sort of game changers for me was thinking about an acronym we call MVP, minimally viable product. And so when we think about health literacy, I think as an academic and as a clinical academic, I would say sort of really helping to not chase perfection, but get things out to the world for people to react to has been really important from a digital health perspective, but while also recognizing that like, you get one shot. Like when people join your app, they're seeing one thing and you have to sort of really make sure you're getting it right. And so couple of the ways I did that is, and this isn't to apply that health literacy is simply simplifying everything, but I think it's been one really key change that I've made in my work. So symptom assessment, typically in clinical settings from a psychologist perspective, I would give you probably like 15, worksheets to fill out once a week. And that would be horrible to do online. We got it down to 2 items every week. That's it. We ask people 2 things every single week. Psychoeducation is what we call like sort of providing background for patients around what it is that they're learning. How do we convey that? If this was, you could tell I'm able to talk quite quickly. Like if this was a therapy session, we have a lot of room to converse. If you're reading on an app, that's very different. People have very short attention spans. And I had to get it down to 3 pages. So I phrase that as not 3 Word doc pages, 3 app pages, 3 swipes. And then I got great feedback that, oh, the amount of content you have is perfect. And I was like, okay, like good to know. In terms of thinking about people's health and behavior change, I really focused on simplifying the main focus of the app, which was really around goal setting and tracking. That is the primary activity that happens every time. So the idea of how do you navigate something very simply within an app interface, we have one primary sort of main action every week that people are doing. And then there's also the ability to do an eating log and track that. Over time, I've thankfully been able to be able to get more funding to support this. We've redesigned Food Steps. And so again, I'm not trying to just say that health literacy is a matter of visual design, but I will say we've put a lot of attention and thought into that. So we think about sort of how things are laid out on the screen. I've engaged with my favorite organization ever is the Center for Health Literacy at the University of Arkansas for Medical Sciences. They have helped us really, and you're seeing, as you can tell, this lorem ipsum is Latin, it's like filler text, but we do a lot with bullet points. We make sentences as short as possible. we avoid the jargon that many of us psychologists really think we're saying. And I now, as I work with more and more teams, I've been able to apply those principles. So I see people's content and I completely, like they say, oh, it's ready to go. You just have to quickly glance at it. And I literally chop it because it's just so long. And if we want people to be able to take in what we're trying to help them do, we need it to be in digestible formats. I was also thinking, and Will, as you were presenting, we spend a lot of time in thinking about how we're going to engage people into research and into this work in the first place. And Will, I'm so pumped for your new tool that you're going to develop. And then I was thinking like, and how are you going to get this out there into the world? And so we made this website and our team is amazing. And I just credit them so much. And then we hired another designer and he completely revised the entire website and the flow of it. And I say this because I'm always happy to know that my designs need iteration, but more importantly, thank you, Marquita. But more importantly, it's really he's teaching me that the way in which we present information, the flow of that, how people go about reading health-oriented content on digital tools matters. And this is something that, I really acknowledge is not in my wheelhouse, right? And so we are partnering more and more with groups, individuals and centers who can help us really perfect that. And I'm now doing what I can to disseminate that to more teams as well. And then the last domain that my team is really now starting to expand a ton more into is now that Foodsteps is working well, quite frankly, we have get really good engagement. So I think that's the other piece I wanted to make sure I say is that it works. And so we're actually actively thinking about like, how do we continue to optimize it? But we're also then thinking about what other subpopulations are being missed. So full circle to what Will was saying, how do we keep designing for subgroups in need? And this is also where actually health literacy or literal literacy changes. So one of the things we're wanting to do is that this is an English only intervention. I admittedly do not speak Spanish, nor am I Hispanic. Do I identify as Hispanic? But we are missing a large swath of people who really could benefit from this tool. And so I would like to translate this. We have a grant under review to do linguistic and cultural adaptation, but as someone with my own limitations in that, really garnering a team of individuals. And one of the people we've partnered with, if we're hopeful to get this grant, would be someone who he's a translator, but he had worked for the American Cancer Society for 20 years doing their cultural guidelines, doing the linguistic adaptation of their food guidelines. And the reason that's relevant is he started to tell me like, well, which population of Latinos are you thinking about? And I was like, okay, like there's variations of Spanish, and I know I'm preaching to the choir here, but there's just so much that there is to learn about language and how that's conveyed in an app. And the reason I think about all of this most importantly, thank you, Marquita, from a digital health perspective, is because again, I phrase it as M&M. You only get one shot. When you have an app, people come on and they see the one thing and they either like it or they don't, and they're going to keep engaging or not. And so you really have to attend to both visually, navigationally, linguistically, and all kinds of components of this when you're thinking about designing an app. And of course, there's technological capacity to do all kinds of adaptations, but still sort of the opening materials. And so that's why our team's really invested in this area. But with that, I'll turn it over because we're really interested in learning from you all where we could keep growing and learning in this way, and look forward to the discussion. I'll leave this up just for a minute so you have our email addresses. This is all 4 of us on the team. And I'll just shout out to our center. We have several human-centered design resources on our center's website. So we look forward to engaging with you further in this discussion. Thank you.
Fantastic timing. Thank you so much. Literally the word that comes to my mind is delicious. Such a delicious panel, such a delicious just smorgasbord of ways in which we're using digital tool development to address health literacy with multiple populations. We have Will using it with LGBTQI plus populations. Andrew, you're using it with populations where you're talking about multiple chronic conditions. And Andrea, you're talking about using this to digital tool development as it addresses health behaviors, food behaviors, and even eating disorders. So I want us all to really just indulge, again, going along with this idea of just succulent, right? Edible ways in which we're addressing digital tool development. But I want us to really just indulge in a really satisfying discussion related with all of these topics. And we had one individual, actually, to be honest with you, we had one individual who brought a question up in the Q&A, and I will address those. Please feel free to bring your questions put your questions in the Q&A. I will be monitoring all forms of question asking, but I do want to ask this one question of either one of our panelists just to do some level setting. We kept talking about this thing called human-centered design. Can we just level set and address and define what is human-centered design? And why is that even important to talk about when it comes to advancing health literacy?
I can start, but I think each of you have unique takes on this as well. To me, human-centered design is like a moral and a practical project. Like morally, the things that we design shouldn't just be tossed over a fence or shouldn't be forced on people. I want the people who use the interventions or tools that we develop to have a voice in shaping those. And then practically, there's research that shows that interventions created without input from end users or other interested parties perform worse. They aren't used as often, they lead to more errors and so on. So I think there's kind of a moral and a practical motivation for it. And then what is it actually? It's definitely not one method. It's a whole field of research, and part of the fun of doing human-centered design is tailoring the methods you use to the questions you have and to the people you're engaging. And I think both Andrea and Will have great examples of how to tailor their approaches to the specific context they're working in. I'll stop there.
Nothing further to add, though. It's beautiful.
Likewise, I'm just echoing a lot of Andrew's sentiments. I feel like, especially within the context of working with queer teams, a group that is historically marginalized and also often disempowered given their legal barriers of age, oftentimes AI tools are designed without any end user in mind. And I think this is a really unique opportunity to have a pretty more or less easy to use interface of something like ChatGPT, where we're able to engage a very non-technical audience to start thinking a little bit more about like what does it mean to engage with an AI related tool, and supporting them in ways to design these tools to better meet their needs.
Lovely, lovely. Thank you all. Dr. Berry, so I have a question specifically for you. There were many interesting statements that you made, but this participant, this listener here said, I thought the idea that individuals wanted something more final at the end of the process was fascinating. So do you think this was more than they desired, their desired input from the medical field to get that final idea? Or was it that they wanted to be brought to the final idea themselves?
Yeah, thank you so much for that question. I have two answers. So just based on what people said about the conversation canvas prototype, it was really not satisfying to people to sort of see the complexity of their personal health situation without then having some traction at the end or some outcome. So I think the experience of living with multiple chronic conditions is like, I am overwhelmed. I don't have a clear direction. It feels like I keep running into tensions and trade-offs. So I need something to sort of clarify that situation and help me move forward. So it was that lack of satisfaction that I heard really strongly from participants. But zooming out, I think it's both. I think people both need the space to sort of process their situation without too much framing or assertions from a clinical mindset. I think some of the communication boundaries around values that we see comes from patients trying to fit into sort of a clinical box, like 10-minute visits, specific topics can be discussed and so on. So I think creating space to process one situation outside of that is really important. But also, patients don't want to tell their doctors what they need. I think the end goal here is sort of bringing patient expertise together with clinicians' expertise and trying to produce a kind of mutually developed plan out of that.
Fantastic. Thank you so much, Dr. Berry. Dr. Graham, now it's your time. Okay. So, is food steps set up to interact with a patient's EHR? They said EMR, but I'm going to go with EHR on this one. Electronic medical records, health records, maybe that's it. For example, if someone has been binging, their provider can check in with them.
Great question. So the answer is no, not at the moment, but there's two components to answer that. So currently the intervention's only available through clinical research trials, but everyone does get a coach. And that was something that I personally was likely going to include and believed in, but then our design work suggested that would be really important because one of the early prototyping activities we did, and you heard that term from Andrew, where you're trialing out different strategies, where we gave people these opportunities to see the different health topics they could work on. And we said, okay, go to do it on your own. And we didn't give them much instruction, and we just wanted to see what would happen. And turns out a lot of people knew exactly what to do, in part because we've been eating for our whole lives. But in other ways, people really did need support in how to implement those behaviors over the week. And so we were really attentive to, if we simply let people completely be on their own, that could actually set people up in a less like, we wanted to make sure people were really set up for success. So everyone has a personal coach throughout the 16-week program. The EHR question, I know you asked a simple yes, no question, and I'm giving you a much longer answer. But the other side of that is it's not yet set up with the EHR. In many ways, that would be a dream. In other ways, that is not such a dream. So one thing that we've found, one of the things we're doing now in our research is actually surveying people to say, at the end of this, are there other people beyond your coach that you would have wanted to know about your progress in food steps? So like your doctor, like a family member who could provide really good at-home support, for example. And we're learning what people might want. But we also know that actually clinicians can struggle with that interaction. Often clinicians would want that feedback of how their patients are doing. And it's really a question of, how are you going to actually implement that in practice? So are you going to do a weekly report? Are you going to do a monthly report? Like, how is that conveyed to doctors? Who's responsible for that patient? When? There's a lot of implementation questions that come about with that, that we've come to learn. Often some settings don't want additional details, not because they don't care deeply about their patients, but sort of where the responsibility lies really becomes important questions. And so long story short is, in the world of digital health implementation, soon we're going to have reimbursement codes to be able to, or if not soon, already now, to be able to reimburse for digital health tools. But there is a whole lot more sort of that we have to solve in order to really make that happen. Very long answer for a simple question. Yes, Michael.
Yeah, so a question for each of you, if it's okay. One of the things that's fantastic about each of your work is you're actually using digital tools to try to humanize the experience, like to improve, humanize, and patients, like make it more patient-centered, more. But one of the challenges are, there's a lot of challenges, but one of them is that even if you are really focused on a target population, there's not one population. In the end, you're looking at hoping to make a tool for a person. And then and even if you want to like learn about these things, things evolve so fast, like so fast, the technology, and then also populations over time. So like, for example, Will, there's a panel tomorrow on Soji data collection, and the interviews they got from younger people are completely different from the interviews they got from older people. And it's so anyway, maybe if each of you could take an opportunity, if you might, to talk about at least generational effects or age effects, because it's such a huge impact on how people interact with technology, and how you are thinking about what to be done about that, and how to have that influence your work for the good.
I can start, but I think all of us will probably have different thoughts on this. But one, I love the question. And I think, again, going back to the fact that I'm trained as a clinical psychologist, I think the one piece that I really tried to change in doing this is the simplicity of what I'm targeting, exactly for what you're just saying. And so we literally, particularly from an academic perspective, we will never have enough money to keep up with the Apples and the Googles of the world, period. Like we just can't. And so instead, my role is really to help understand what are some of the core processes from a tool that we could use technology to improve behavior change or to simplify and like to make an experience more humanized, exactly as you're saying, but not that, I mean, maybe one day I'd become a billionaire, but like really that's not the goal, you know what I mean? And so it's like, how do I use this as a tool to improve human process? So, and understand it. The reason I bring that up is because for me, my approach, whether it's generationally or sort of the fact of how technology paces, is to really change my thinking and what I put out there. And so that's where I make the self-deprecating jokes about how ugly the app was to start. And we thought we did a good job, but like, it was like the literal like fanciness of it didn't matter. We needed to just see like, can it work? Because by the time the 5-year study was done anyway, the like literal, like all of the technology, you know, features would be different. And so really using sort of where our platform can be an opportunity to learn like how to change behavior in this way without as much thinking about like, well, should it be an avatar or an emoji or, you know, because that really can change over time. And so for what that's worth, that's been one of our approaches. And then also to really understand from the human-centered design process, like where across generations are people, quote unquote, like really struggling, quite frankly, like where is the common denominator of like the challenge for people in changing their behavior and how can I design around that? And that's become, I think, more and more, I have found that's a much more universal experience in a really positive way with nuance, but overall universal.
I can go next. I think within the context of my project, while creating a custom AI tool is like a great deliverable, I think what I'm more excited about really is creating some sort of like website or toolkit that has these like AI literacy guidelines for other queer teams to navigate. As like we mentioned, technology is advancing rapidly, and sooner or later, you know, like the particular model of a chat GPT that we're using today might be obsolete in a couple of months. But the lessons learned from how to navigate and how to adapt certain AI tools, I would argue would be more or less, you know, like replicable and like adaptable over the next couple of years. And so part of the reason why I'm engaging human-centered design and specifically code design with these teams is to really get them to be AI designers or experts in the ways that they can to influence technological design. And by getting them to be really intimately involved with understanding a little bit more of the mechanisms behind AI, they'll be able to share these lessons to other queer teams who might be navigating other AI tools for other types of health, sexual health information. And so I think that's probably like why one of the main attractive features of like this co-design process is to really figure out how do we best support these teams to become basically peer educators for other queer teens who are navigating this technological landscape.
Yeah, I think you both make strong points, and as I feel like I have a bunch of different answers. I think the one that I landed on the most is in response to like, what do we do as technology changes rapidly and as people's values change and cultures change? When doing human-centered design, kind of the object of our design, the thing that we're designing, how we scope that could maybe future-proof it a bit. And so sometimes we'll talk about designing technology-enabled services. So rather than designing an app or a website, we're designing a service that, and technology might play a role in that. And so I think by defining sort of what's the value being co-produced in a healthcare service, and then right now, what are the best technologies to support that? Recognizing those could change. I think that's sort of my answer is don't just focus on the technologies, but the technology-enabled service.
Thank you. And I actually want to add a little bit to that as well. As I mentioned before, a little bit about the work that I do. I actually focus on digital tool development in rural older adults, which is just such a rewarding, and I mean it's a passion of mine. It's such a rewarding experience. And one of the things that I don't have any answers. I have more questions, but I do want to reveal a existing gap in the literature. And is that not only is the technology developing very rapidly, but the idea of how our existing paradigms of research are really broken and inadequate, antiquated to address the moving population, excuse me, the rapid development, and at the cost of marginalized populations and populations that don't often don't often participate in clinical trials, like rural residents, like our older adults. So we're also addressing, so there's also a need for equity to be addressed as well. So not only is it rapidly developing, but how are we beginning to also address equity? How is this technology beginning to actually penetrate and reach those individuals who most likely are going to need to use the healthcare more than the focus groups with the young folks, the young white men who are doing in developing the digital tools at this moment. And so I don't have an answer there, but I do want to bring up and kind of do some signposting to say equity does need to be addressed. I actually have an R01 that was just funded, and we'll begin to use implementation science to address equity and how do we actually design and address sustainability at the beginning, because the gap in the research says we're not doing that. The gap is we're not addressing equity, and we don't know how to look at sustainability at the beginning before the development or the continued development of the digital tools. So I just wanted to throw that in there because I am a champion for using digital tool designs and development, but we also make sure that we're reaching the people who are not in the room who need to be reached. And because I'm the final one saying that right there, we have about 4 minutes left. I saw that Dr. Graham, you addressed one question specifically that was for Dr. Berry, and I see that has been answered. So I'm going to go to the last question that we have up. And I also want to make sure, did we adequately answer your question there, Dr. Pache, Orslow?
Michael's fine, yeah, but that was valiant. Yes,
I tried really, really hard.
absolutely, absolutely. The market will take care of the worried, wealthy, and well. We're going to have to step in to make sure these tools work for people who aren't in that spot. The vulnerable populations, like, it's not going to inherently just be done automatically. Not only just because of, like you said, Will, there's like inherent bias built into the learning models. There's also just inherent bias built into the market, and not a single one of my patients who use heroin are using a Fitbit. If you think about like the most successful health app ever, total market failure. Not a single one of my diabetics with an A1C over 12 are using a Fitbit. So anyway, there's a lot of work to be done. But I think you saw some people starting to pop onto this screen who are speakers in the next panel, which is why they were showing up. So, but they popped off because we scared them away. So maybe if people have closing visions about where you want to take this or something like that, that'd be awesome, because people are really hopeful, but we know that it's going to take a lot of work.
And I will leave the closing visions. Yes, go ahead there, Dr. Grant. No, I was
just gonna say it's outstandingly said that we still have a lot of work to do. And I will say, as a psychologist, there's often questions around, like, by making apps, are we gonna put all of us out of jobs? And God will, like, we'll never get there, right? Like, so we all, like, there is a lot of work to be done. And so glad that we can all be on this panel today and with attendees of really trying to champion for better health.
Yeah, I'll just jump in to encourage you all to design digital tools with people rather than for them. I think that's my closing idea.
Likewise, I always ask, as a social worker turned technologist, I always ask myself, what are the assumptions that we're bringing in when we're designing digital health interventions or any sort of technologies? And oftentimes, by working directly with your end users and the populations you're working with, you learn a lot more about what's actually needed.
fantastic. I was looking, I do not have the ability to emoji claps, but thank you all immensely. Fantastic discussion. And you all have a fantastic rest of your day.